Thank you. Wonderful set of talks. We have some time for questions. We have a whole half hour set aside. We can fill it or not, but let's see what questions are. John.
Hi, thank you very much. Lovely stuff, the IDH mutant stuff there. Do you have a concept of what resistance to IDH1 inhibition might be? I mean, we've been going on about resistance to the kinase inhibitors all day. This is a metabolic pathway. Is there such a thing as resistance? Is there a bypass pathway? Have you got a feel for that with your CRISPR, using the CRISPR?
Any thoughts from the panel? Resistance, metabolic resistance.
I mean, I think at least in our samples, and certainly what we're looking at is, the effect of other co-mutations. So, for instance, in GBM, that's probably a good example. In low-grade glioma patients, the overall mutational burden with respect to other mutations are far fewer. And as these tumors sort of transform over time, they become much more heterogeneous with respect to other mutations. So it's unclear, how relevant the IDH status becomes at that point. So it's probably going to be much more complicated as you look at different tumor types. One question that has come up is, is there a wild type enzyme activity or some other, bypassing mechanism by which maybe if you're not blocking wild type enzymes or the other mutant variant, could there be an IDH1 patient who then ultimately ends up developing an IDH2 positive clone? So, we certainly, that's why these biopsies are so useful, and also interrogating the circulating tumor DNA, at least in the clinical samples that we're collecting.
Just one small point that I wanted to make is that in terms of most cell lines from solid tumors, or all the ones that have been studied so far, IDH is not a driver for the in vitro proliferation. So work like what Lei showed indicates that the ongoing expression of mutant IDH and the production of 2-HG dramatically changes the cell physiology, because he can completely shift the dependencies on various metabolic pathways by switching on or off the mutant enzyme. But nevertheless, one isn't even studying an oncogenic driver in the in vitro setting. And this is an issue of how good our models are going to be in any of these in vitro studies, because we don't have a dependency, unlike kinase inhibitors where you see something die in a dish and that replicates what you see in vivo. Here, in various models, there's a slowing in preclinical models, like is seen in patients. But again, it's a very different paradigm.
I'm going to ask a question. With regard to loss of ARID, do you suppose that EZH2 inhibitors will have a role in these tumors that have lost ARID? Is that, I know in terms of how these two complexes, switch SNF and the I think PRC2, what's your sense about that?
Yeah, actually, there has been a lot of there has been a lot of work on that. We haven't really done much in our own hands, because we've been trying to figure out what ARID does on its own. But Charlie Roberts has come out with a recent paper that has shown that knockdown of the EZH2 is a more effective way of getting synthetic lethality than the enzyme inhibitors. So it's uncertain whether or not they're going to work, and that's something that we're going to do in the mouse models.
Yes?
Yeah, I have one question with AG120, especially with glioblastoma, because in our group we have a really problem killing the GBM cells. So how effective was AG120 when you consider the blood-brain barrier? Because nothing goes through it. So how effective was, especially for GBM?
Yeah, I think that's a good question. So AG120 was not specifically designed to be blood-brain barrier penetrant. We do have a sister compound, AG881, that's currently in phase 1 development, that is blood-brain barrier penetrant, and that is a pan-IDH inhibitor, both IDH mutant 1 and 2, as well as wild-type enzymes. So we'll learn more, I think, over time. The MRS is meant to serve as an imaging biomarker, so you could presume that if 2-HG goes down based on MRS imaging, that the drug is actually penetrating the blood-brain barrier. The challenges that we face with MRS, however, is that it's not standardized across centers. There are different vendors. There are different ways of placing the voxel to be able to get an accurate measurement. So part of what we're doing at Agios is standardizing a protocol that we can use across centers so that we can hopefully answer that question, at least with some of the data we've generated with AG120. It's hard to get biopsy samples, as you can imagine, right, in these patients. There's certainly been a lot of thought around doing a perioperative window study so that perhaps patients could get dosed and then you go on to collect the tissue samples. So there's certainly various activities underway to help address the question that you just raised. And then, of course, combination strategies with radiation and or chemotherapy are also within the realm of what we're planning.
One question with ARID1A. There's a hypothesis, the BRCAness, and there are a couple of genes which are related with the BRCAness. So have you ever looked BRCA1 mutations in your HCC samples?
BRCA1 mutations, we have not, we haven't done extensive sequencing, but I don't recall there being a statistical significant connection between BRCA1 and ARID1A, but I could be wrong. I know that there's sensitivity to DNA damage repair agents in ARID1A mutant cancers, but we haven't looked at that.
So the reason I am asking this question, because we got from Foundation One almost 2,000 patient data from melanoma patients, where they kind of suggest as some kind of correlation, although because in melanoma we don't do the BRCA1, but they think there's because of this 2,000 patient cohort from Foundation One data, they see there's some correlation might be happening there.
Yeah. Yeah, that's very interesting. I think that the various synthetic lethal strategies that you're alluding to are going to be really important to test. It may be in the in vivo models that we have. So connecting ARID1A with DNA damage, connecting ARID1A with EZH2, and connecting ARID1A with synthetic lethality in the other components of the complex. So those are the three therapeutic strategies that really need to be validated with better tools.
Okay, thank you.
Great. I'd like to thank the speakers. Thank you for coming, Hao, Susan, Lei, and we can step off and Juan will come and introduce our next speaker. Oh, I have another question. Sorry. Okay.
Sorry.
Sure.
I have a quick non-scientific question. Susan, you mentioned that the phase 3 study allows for crossover, and I was wondering if you could just explain a little more about what that means, and also when that's put into practice for a patient, what that really looks like.
Yeah, sure. So it's complicated, right? You can imagine a lot of conversations went into that decision, but so crossover effectively means that when a patient has radiographic progression, based on their clinician's determination of that, operationally that will be communicated to myself and another medical director on the program, and we would basically confirm that the patient meets progression criteria. Then unblinding would take place, and what that means is that the patient as well as the investigator would be unblinded to the treatment assignment. So if at that point the patient's on AG120, they move on to something else. If they're on placebo, they have the option to cross over. So it's certainly not mandatory. It would be at the discretion of the patient and the treating physician. The patient should meet eligibility criteria, however, to cross over. So we certainly want them to be as healthy as possible to be able to cross over so that the risk versus benefit profile is favorable for the patient. Does that answer your question? Okay.
Yes, Greg.
Yeah, I also have a non-scientific question. I'm just wondering, how does one root for the Patriots?
It's not so hard.
On that funny note, thanks to our speakers. All right.